Hello, and welcome to the DSERA Clinical Education Multi-Specialty Podcast. I am your host, Jill Frost. Today's episode features a conversation between two obesity medicine experts, Amy Butts, an endocrine physician associate at WVU Medicine Wheeling Hospital and immediate past president of the American Society of Endocrine Physician Associates, and Dr. Nicholas Pennings, professor of family medicine at Campbell University School of Osteopathic Medicine and director of clinical education at the Obesity Medicine Association. They are here to discuss the latest advances in obesity care and how to best integrate novel obesity management medications appropriately in your practice. This episode is part of a larger educational program titled Engage, Empathize, Empower, Enhancing Obesity Outcomes Through Strengthening the Patient-Provider Therapeutic Connection. For more information on Amy and Dr. Pennings, along with a link to the larger education program, please visit the show notes for this episode. Now let's get started and hear what the experts have to say about this important topic.
We're here today to talk about new and emerging incretin-based therapies for obesity medicine. So this is a very exciting time as new obesity medications are coming on and the landscape is changing very rapidly. And I think what's really exciting about this is it creates an opportunity for primary care providers to be the first point of care in obesity medicine, to initiate obesity therapies. And this is really a great opportunity because it is the primary care providers that are seeing the patient's first line. And this gives us an opportunity to treat obesity like we treat many other chronic conditions like diabetes, hypertension, dyslipidemia. These are all chronic conditions, and like obesity, they're driven by biology. Amy, you want to tell us some more about some of the newer therapies?
Sure, absolutely. Thank you. And I couldn't agree with you more. It's an exciting time in obesity management. And, really, we have choice now, and we can decide on what is best for the patient using a person-centered approach and some shared decision making. And we're able to really break down for each patient what types of medications are out there and what indications they each have, including comorbid condition risk reduction like ASCVD that we see now with semaglutide, orally and injectable. And then, of course, we also have indications to help not only reduce weight, but improve moderate sleep apnea with medications like tirzepatide injection. And then we now have oral options, which are really great to have as an option for individuals who do not want to take injections, or for whatever reason they choose an oral version instead. And these medications are great in the sense that they allow ease for patients to use as well. So really the key is selection, right? And we shouldn't forget cost and the fact that sometimes going back to some of the older medications that we have had for obesity may be the correct choice for an individual who maybe cost is an option or a problem, or if we have an issue where maybe they are contraindicated to utilize some of the newer medications. So it's an exciting time because patients finally have choice in order to really tackle this chronic relapsing disease state we know as obesity.
Well, that's great, Amy. And I think we've got some opportunities to unpack those great points that you made. But I want to start by just talking about the mechanisms and the treatment landscape that these incretin-based therapies, they target appetite. And one thing that I think is foundational in the treatment of obesity is that, we talk about eating less and exercising more. And of course, that creates a negative energy balance, which allows you to lose weight. But the challenge with that is that increases your appetite. You're more hungry, and that is not a good feeling. And that's where these medications can really be very effective in targeting appetite, helping to improve satiety so that you're not feeling hungry all the time when you're calorie restricting. And in addition, you help glucose control and lose weight. we now have some really nice options with new oral medications, including a small molecule non-peptide that is expanding the options for our patients. And this really matters because patients can be very reluctant to do injectables. They are sometimes very hesitant, and the option of an oral medication is very exciting. Amy, maybe you want to talk a little bit more about some of the comorbidities and other components of using incretin-based medications.
Absolutely. So I think it's great to kind of talk about percentage of body weight loss, right? So looking at efficacy and our older obesity medications, although they provided us with a percentage of body weight, nothing like these newer incretin therapies do provide us. So if we look at one of the older medications that we used to use, like orlistat, that only really provided a 3 to 5% body weight loss, and with the side effects, it was really uninviting, or many individuals chose not to pursue something like that for that small amount of weight loss. And then looking at phentermine, really, we know phentermine helps patients. However, we're looking at a 5 to 10% weight loss reduction. And in individuals we know that are using the higher phentermine dose, it really is not recommended to use longer than 12 weeks. And so we then moved into an era where we were getting some more medications that could be used for long term management, such as a combination of phentermine and topiramate, or naltrexone and bupropion. And once again, although these medications can be used for long term use, percentages of body weight really varied anywhere from 5 to 10%. And so, moving into the newer medications that we do have access, we're getting greater body weight reductions, and we're really focusing on shutting out food noise. And it is meant for long term management. And so, these are medications that patients can continue to take long term in order to maintain and be successful. We know that obesity is can be a very mental distress for individuals. It's a lifelong struggle, and many of them have been shamed and felt defeated over the years, with negative feelings and negative comments being made to them. And so the fact that with medications like semaglutide, we received anywhere from a 12 to 18% reduction in body weight. And tirzepatide, we received as much as 15% at the 5 milligram dose, and 20 to 22% with the 15 milligram dose in Surmount 1. And then now, even with pills, for those individuals that do choose a pill option, the newest drug, or orforglipron, provided a 12.4% reduction in body weight. And so we're getting some really robust percentages of body weight loss that make a true impact in the patient's overall care. So I think it's a win, and the future is bright. Don't you agree, Dr. Pennings?
I agree, and on top of that mental distress that comes with obesity, with the stigma and bias that our many of our patients face, the idea of taking an injection can also be very distressful for patients. And so now having some oral options that are really potent and really effective is a very exciting time for us. Now, oral doesn't necessarily mean that it's easier. Oral semaglutide requires a very specific type of administration where you have to take it in the morning on an empty stomach with no more than 4 ounces of water and only water, and then waiting 30 minutes before you eat any other food, beverages, or take any other medication. So there's some challenges around using the oral medications. The orforglipron now has an option of taking the medications with food. So that's an exciting new addition that we're seeing today. Would you agree, Amy?
Absolutely. I think that's the one thing that separates or from semaglutide oral, is the fact that the convenience of this pill, that really definitely was sometimes an obstacle for my patients with timing with the oral semaglutide. And so the fact that an individual can get up in the morning, they can take that pill with or without food, and there's no problem with timing. They can leave the house, get on to their day. I'm a busy working mom, and so I know what my mornings are like. It's really nice to have that option for those those patients.
That is nice. And you mentioned about all of the different outcomes that we saw in the different trials. And of course, you can't compare head to head unless you do a direct study. And that has been done with tirzepatide and semaglutide. But many of the other medications, we don't have direct head to head studies, but we see significant weight loss with all of those medications. And I think that's really exciting. That one of the things that's also a little bit confusing sometimes is we hear reports of different percentages of weight loss. Part of that is based on the design. So there's something called estimands that are used to calculate the average weight loss that patients are experiencing. So there's the treatment policy estimand and the policy product estimand or efficacy estimand. So these are ways of calculating how many patients lost weight or what the percentage of weight loss was. And the difference is really the treatment policy estimand. You'll see the percentage of patients that have lost weight that started the medication and what the average weight loss for all the starters were. So I distinguish it between like the starters and the finishers. So the treatment policy estimate looks at how many people started the program and what was their average weight loss at the end, whereas the efficacy estimate looks at the number of people, look just at the people who completed the treatment protocol according to the protocol and were able to finish the right to the end and what was their average weight loss, and that's often higher, and so that represents our patients that are able to go on the product, stay on the product, and so that can be a little bit confusing, but we see sometimes like with the oral semaglutide, the treatment estimates or the efficacy estimate of almost 17%, which is quite impressive.
Yep.
So both of those, both oral semaglutide and orforglipron, show clinically meaningful weight reductions, which is very helpful for our patients.
I agree. And I think the messaging really is that it is not a one size fits all for every single individual. And I think the messaging is that we now have powerful options that will make an impact on our patients' lives and reducing their comorbid conditions. And, unfortunately, we live in a world where sometimes we are more focused on the number of on the scale or the percentage of body weight loss versus the impact that even 5 to 10% of body weight reduction can do for us as far as reducing our cardiovascular risk. And so, having that conversation, we as providers having that conversation with our patients, making sure that we explain to them that it's more than just a number, but the fact that these trials support that we have products in the world today that can fit into anyone's lifestyle that will give them impactful, meaningful results in the long term.
What are some of those conditions that you're looking for to treat with weight loss?
As I spoke to earlier, so first of all, we know that atherosclerotic cardiovascular disease, a patient can 5 to 10% body weight reduction can impact and reduce that risk. We know that when it comes to the benefit that we see with joints and physical mobility, even a 5 to 7% can make a huge impact on individuals. MASH, right? Fatty liver disease, metabolic dysfunction associated steatohepatitis. We know that we're seeing impact with 5 to 10% in these individuals as well. Once again, it's these comorbidities that it's not just the number, it's the comorbidities and how we can reduce patients from developing, cirrhosis of the liver and patients developing the need to have open heart surgery or their 12th stent. And so we really need to move the mark in looking in that and reminding them as we age, our goal is to slow the progression of these events. And doing this by helping them with the weight loss will impact them.
Yes, it's sometimes said that obesity is the mother of all diseases, and there are so many diseases, some estimates of over 200 different diseases that are caused by or made worse by obesity. And you listed a number of them, but also the quality of life really matters for individuals too. So when we're treating these diseases and we're helping people get healthier, that's something I really enjoy about obesity treatment is the quality of life improvements. But choosing a new medication can be challenging. And sometimes, particularly for a medication like the treatment of obesity, I think shared decision making is such an important part of guiding patients and working with patients and making sure you're finding a treatment option that fits best into their lives. There's a framework that we use for this called the 5 Cs that is sometimes very helpful. First, identifying contraindications and cautions that should be used. Are there specific conditions that the patient has that would pose a contraindication or something we need to be careful about, something in their history? Also, what are their comorbidities? You listed a whole bunch of things like blood pressure and diabetes and sleep apnea and MASH. These are all important. They help us to decide what medications might be ideal for this individual, but also listening to the patient. What are their thoughts about medications? What are their fears and concerns about medications, either the type of medication or the route that we are giving it to them? And what other medications are they on? Are they on certain medications that might be promoting weight gain? And we should always be looking for those medications. And then what combinations of medications might be beneficial? Perhaps if they have a condition such as depression, you might be looking at a medication that contains bupropion that might be appropriate for that patient. But also, if they're on other medications for depression, we want to be concerned about those things. So these are things that weigh into our decision making. And then finally, cost and coverage is the last C. Medications can be expensive, and coverage is spotty at best. But it's nice that we have some options that are more cost effective, and some of the pricing options have come down, which is beneficial. What do you look for in underlying diseases in patients with obesity, Amy?
So I definitely always assess cardiovascular history. I look at hypertension, dyslipidemia, diabetes. Does the individual have obstructive sleep apnea? Do they have MASH? Do they have mobility issues? And so, based upon those factors and those phenotypes, I then look at what medication best targets or has that proven indication or in proven benefit in clinical trials. So, as I've said earlier, once again, semaglutide has been found to reduce risk with individuals who have established ASCVD. We know tirzepatide has been shown to be beneficial for those who have moderate obstructive sleep apnea. Semaglutide injection has been shown to provide benefit with MASH. Really, our goal is to help patients and utilize medications that we know provide that secondary benefit, not just the number on the scale. However, unfortunately, as you spoke to cost and access, right? So we are, seeing some coverage occurring in individuals for obesity if they have obesity with one of these comorbidities. So I have been successful in getting semaglutide covered for individuals for the ASCVD. I have had a few individuals with the tirzepatide approval with the sleep apnea, but not all insurances. So we still have barriers. We still have work to do as far as finding access for our patients in this space. However, as you spoke to, there are a lot of cash options these days. And these newer agents, all of the pharmaceutical companies are competing. And at this point, all have direct manufacturers. Individuals can purchase these medications directly through their pharmacy at lower cost. And it seems like every month the prices are getting a little bit better every time. However, we know these cash prices still are not sometimes affordable for individuals, especially in the areas where we know social determinants of health is such an issue. I work in the state of West Virginia. Unfortunately, we live in a low socioeconomic area. So I am utilizing older medications in some situations, not as a first line option, but something is better if I can get some benefit for my patient. I have to choose older options in order. When a patient asks me, well, what do you think is the best medication? I always say it's the one that you can afford to take, really. And as I've said earlier, not a one size fits all. So, really meeting the patient where they are at in their socioeconomic status.
Yeah, that's a great point. And, the newer medications that have come out in oral form also have a lower price point. So that also creates some better affordability. But it's also important to remember that just because they're oral does not make them any less effective. It really is impressive, the effectiveness of these oral GLP-1 agents. And so they can have an equivalent response to the injectable forms. And so that's really nice to see. We also need to make sure that our patients don't have any contraindications. I mentioned that earlier, but some of the specific things we want to look for with the GLP-1s is there a personal or family history of medullary thyroid carcinoma? And we would not prescribe it in those patients. Now, there's other types of thyroid cancers that it's not a contraindication for, and medullary thyroid carcinoma is an unusual form, but you need to know whether or not a patient or a family member has that, as well as multiple endocrine neoplasia 2, which, if they have a personal history of that, and for some of the medications, a family history of MEN2. GI side effects are common with these medications. Fortunately, they're usually not too severe and often transient so that they will subside over time. And altering the dose escalation schedule can be helpful to minimize those side effects. But the side effects sometimes are severe and sometimes can even lead to dehydration from severe GI side effects, and that can result in kidney injury. So we want to be wary of that and warn our patients about that. With weight loss, we can have gallbladder problems, cholelithiasis, cholecystitis, and it is a little higher with the GLP-1 medications, as well as we want to be concerned about pancreatitis. And if they develop symptoms of pancreatitis, abdominal pain, back pain, nausea, vomiting, those are reasons to stop the medication. In our patients with diabetes that are on insulin or sulfonylureas, we want to make sure that we don't cause hypoglycemia, as these medications will decrease insulin requirements. And so we want to be proactive and adjust insulin accordingly if they're on those medications. And lastly, these medications also slow gastric emptying. So we want to be mindful of that and make sure our patients know to alert any of their providers that are going to take them to surgery, and work with the anesthesiologist to make sure that they stop these medications with the appropriate amount of time so that they don't have any residual gastric contents and increase the risk of aspiration. Are there any other things to be concerned about, Amy?
So I think when it comes to the oral medications, it is very important for us to talk about interactions with other medications. And so what we know about semaglutide orally is that when individuals are taking levothyroxine, semaglutide was found to increase the absorption of levothyroxine. So in our individuals taking that, it is just very important that we monitor TSH levels and adjust medications appropriately. Some other medications that have a narrow therapeutic window, like warfarin, although warfarin's not used as much as it used to, there are some pockets that it's still being used. We need to be careful and cautious with that as well. We do know that tirzepatide, it's important to discuss oral contraceptives. So, with individuals taking tirzepatide, we know that in the trials, they saw a decrease in effectiveness of oral contraceptives. So, it's important in individuals taking this, and also tirzepatide and or forglipron both have this contraceptive counseling that needs to be done, where discussing with individuals, it can decrease the effectiveness of a hormonal contraceptive. So you want to consider a barrier method, especially within those first 30 days after starting the medication. And anytime you escalate or increase the dose, it's very important to make sure that these individuals are using a second barrier method or a non-hormonal form of contraception to avoid any type of pregnancies. The other thing with orforglipron that's important is there are some caveats with it as well. We know that simvastatin, although we don't use as much simvastatin these days, especially in our high-risk patients, we tend to use rosuvastatin and atorvastatin, but there are some individuals still out there that use simvastatin. And with this medication, it can increase, so orforglipron can increase the effectiveness of simvastatin, so it's not recommended for patients to be on more than 20 milligrams a day. We also need to caution use with strong CYP3A4 inhibitors that these can increase levels. So these are medications like clarithromycin, ketoconazole, and verapamil is probably one of the more common chronic meds that may be used in individuals. Strong CYP3A4 inducers can reduce the effectiveness of orforglipron, so it is recommended to avoid this in these individuals as well.
Yeah, so there's a lot of things to be thinking about. And then also about blood pressure and A1C. We want to be monitoring those and lipids, as well as being able to assess what their mood is, that some of these medications can affect individual mood. I think those are important. But it's also important that we follow dietary interventions, right?
Absolutely. That's the foundation, right? It's very important to remind patients that all of these medications are to be used in addition to lifestyle modifications, including dietary and exercise. So we want to focus on really reinforcing protein intake. We know that patients, when trying to lose weight, should be intaking 1 to 1.5 grams per kilogram of body weight a day of protein intake. That's anywhere from 80 to 120 grams for a female and 100 to 150 grams a day for a man. We also wanted to talk about fiber intake. We know that these newer meds slow gastric emptying. And so, with that, we can see those issues like constipation and diarrhea. So it's important to also discuss with patients trying to get in 25 to 30 grams of fiber a day. And that can be done either with food or the combination of food or supplements, fiber supplements, but really encouraging that. And then hydration. These medications, they shut off food noise, but they also sometimes do shut off the desire to drink. And we know that acute kidney injury can occur with medications if patients become dehydrated and have severe GI intolerance. So it's important to encourage patients to focus on drinking 64 to 100 ounces of water a day. And then exercise, resistance training, especially in the aging population. We know that we will lose muscle mass as we age. And we also know if we're not intaking enough protein, we can lose muscle mass as well. So, encouraging individuals when participating in activity to really focus on resistance training with the goal of it being 2 to 4 times a week, at least 20 minutes, 20 to 30 minutes would be ideal. And that's not only for muscle wasting, but improving balance and reducing fall risks. Do you have anything else that you tell your patients, Dr. Pennings, or anything that you would add that I haven't brought up?
No, I think you cover that quite well, but we definitely want to avoid frailty, particularly in our older patients. So that exercise component, that adequate protein intake, and understanding that patients that are elderly have a decreased bioavailability of protein, so they have an increased protein requirement. So I think those are all very excellent points. And we often think about decreasing hunger, but we often we don't always think about decreasing thirst. And that is an important point that you made, that we want to make sure our patients are drinking enough. But with these new therapies, it's really very exciting that I think creates a great opportunity for primary care providers to be able to treat patients with obesity early on, but really take on that patient-centered approach, combining it with lifestyle therapies and also being able to initiate therapy early on.
I agree. And I think the point is we, as the provider, being proactive with our patients and really asking for permission to discuss their weight. And not only for that external appearance, but what we know that obesity, the impact that obesity has on our overall health and our long term complications and decline. So I enjoyed so much speaking with you today, Dr. Pennings. You're such a joy and such a pleasure and a wealth of knowledge. So thanks for including me on this podcast.
This was a great discussion, and I think this is a great opportunity for our primary care providers to be able to take that proactive approach, but also to make sure that it's part of a comprehensive treatment plan that includes long-term care for obesity. So it was great talking with you today, Amy, and I look forward to talking again sometime.
Thank you, Amy and Dr. Pennings, and many thanks to you, our listeners, for joining us. As a reminder to view the full program, Engage, Empathize, Empower, Enhancing Obesity Outcomes Through Strengthening the Patient-Provider Therapeutic Connection, please click the link in the show notes. And be sure to check back regularly for more episodes on important multi-specialty topics.